Make you the presenter.
Okay. All right, can you guys see my screen okay?
Not yet. There we go. Yep, all good.
So this is I'm going to show 3 all ordered by the same interventional cardiologist, all CTA TAVRs, and all with kind of unfortunate findings. So this first one was a lady with bicuspid aortic valve. You can kind of see the aortic valve picture here with the characteristic fish mouth appearance with a fusion of the of these 2 cusps. And then there's this irregular outpouching back here. And so she was actually referred to him for not aortic stenosis, but aortic regurgitation. And here on the long reconstruction, we can see that there's basically just a blowout of the wall of the sinus of valva on that side. And it's actually also fistulizing above and below the valve plane. So this is a paravalvular abscess or contained rupture. And which was kind of unknown at the time of the CT. She didn't do well after that. I think she passed away shortly thereafter. This is the next TAVR planning CTA that I read from the same provider. What we can see here is this avidly enhancing mass in the AP window. And let me pull up there we go. And so this is the first phase of the study. This is the gated heart, and we see some salt and pepper. It's kind of on the top of the image, and it's probably in the superior pericardial, the superior aspect of the pericardium. And on this sequence, which is a few seconds afterwards, maybe 5 to 10 seconds later, we see it's become even more avidly enhancing, with probably still a couple areas that are hypo-enhancing. So this is what I thought was going to be my second paraganglioma in as many months, and we can see here on the gated image that it moves with the heart on that image, and then here it's at the top of the image up here. It's this structure that's kind of has this tendril that's snaking along the LPA there. And sure enough, it seems to move with the heart, which would be consistent with at least part of it being within the pericardial space. And here's the corresponding axial SPECT image from the MIBG, showing it's very avidly or very, very hot on that, lots of uptake. Here's the MIP showing that focal tracer uptake. So this is going to be likely another intrapericardial paraganglioma. And then the third study I read from the same provider that day was this one. This is a guy also undergoing evaluation for TAVR. And what we see is this lobular hypodense filling defect or mass within the left atrium, kind of associated with the right superior pulmonary vein ostium. And I'm not sure, but I think he may have had a history of prior pulmonary vein ablation. We're still kind of trying to determine that. So this is probably going to be a thrombus, but this would also be a good look for a sarcoma as well, and obviously very different management. So we'll probably get a follow-up MRI for this patient. And another nice example of how delayed imaging can help with the left atrial appendage. You see this filling defect here. Certainly the tip of it is very hypodense. More proximally, there's some mixing there. But then on the non-gated CTA done a few seconds later, we see that fills in completely. So just filling just a slow flow. And then also going along with that being potential thrombus, you can see sequela of a prior LAD infarct with thinning and akinesis of the anterior wall, nicely demonstrated on this setting. Cool. Those are my cases.
Wow, all on the same day, huh?
Yeah, all the same day. For the same interventionalist, I told him, was like, you got to stop ordering CTs.
Yeah, wow, those are impressive. So even though the lady with the perivalvular abscess was just routine.
Yeah, she'd been diagnosed with endocarditis a few weeks earlier, and had been discharged with, I think she was in the hospital for a week or so, probably had an echo. And I've seen this a few times now where things like this are missed on echo, or maybe misinterpreted. And a lot of times stuff like this, it can present mostly as just kind of like infiltration around the fat in the aorta, which is probably not going to be easy to see on echo. It may show up as echogenicity, increased echogenicity, and on CT as increased soft tissue kind of in this area between the aorta and the left atrial wall. And then a lot of times, yeah, they'll go to this, which just frankly pops open. But yeah, she had been, that was either several weeks or even maybe a couple months ago where she had that inpatient endocarditis treatment. And then she was referred to this as an outpatient, not so much for aortic stenosis as aortic regurgitation. And in talking to the interventional cardiologist, he thought maybe this was the source of the acute regurgitation since it's fistulizing both above and below the valve plane.
Okay, cool. Well, thanks for that explanation. All righty. Let's see who we've got on. We've got Howard, David, Peter, Travis.
I can go.
All right.
I'll show 3 quick ones here. I'm going to be gone next week, so. Yeah, here's a nice one that came up the other day, and I know that this has been shown before. I think it's important to revisit it whenever we can, especially in this context. The history is rule out pneumothorax. You can see there's bilateral superficial drains. This patient had undergone bilateral mastectomy, and there is a small right apical pneumothorax, but of course you can see how it's confined to the right upper lobe, which is collapsed. And so you can see the line right there. Yeah, so this is, and then of course, so obviously this is not something you treat with a chest tube, and then on the subsequent radiographs, as the right lung re-expands, it goes away. So this is a true ex vacuo pneumothorax in this case. So have you guys ever seen one that wasn't in the right upper lobe?
Yep, I have.
It just seems like,
particularly in the context of placement of endobronchial valves as emphysema treatment, in which the left upper lobe bronchus was, or bronchi in the upper lobe were closed by the valves. So I've seen it on the left side twice in that context.
okay. Yeah, I think
so
it's also important.
Yeah.
Go ahead.
Do you presume
Howard?
that the patient had something like secretions, intraoperative secretions, or an aspiration episode? Something.
No history of aspiration. I think it's probably just secretions and plugging, because this next radiograph was just a few hours later, I think. Or maybe, let's see, which one was the next one? I guess it was the next day, but still, it was the next morning. So, but they didn't do any intervention in between. Of course, it's most important not to place a chest tube, because we certainly have seen pleural injury from breast surgery in the past, although rare.
So, Travis, the idea that this is confined to this place because it's just filling the space evacuated by the collapsing right upper lobe, or is it thought to be extrapleural? Because I think these things usually stay very confined. I've seen it with right upper lobe or left upper lobe, and it's just exactly where that lobe was. It doesn't seem to track elsewhere, and I wonder if it's confined.
I'll ask, I think Howard's the one that's pulled up some of the original literature on this. I don't know the exact mechanism, but you're right, that's what we see in these, all the time. I don't know if anyone knows for certain.
Now, if you go to the last radiograph, there almost seemed to be some opacity or something there.
Yeah.
Is that going away?
I don't know. This was the last one that she had. She had a pre-op radiograph. There was nothing there. So I don't know if it's a little bit of fluid in the fissure or if it's a little bit of, just residual atelectasis. But yeah, it's not a mass.
Okay. So.
All right, this is a really cool radiograph. I've mentioned this before, and I know others have mentioned this. I think this is maybe the best example of this that I've seen in a long time. About, I always tell our fellows and residents, be careful about overcalling pleural effusions on radiographs. I wish we could poll the audience right now to see, how big we think each sided pleural effusion is in a case like this. This patient, as you can see, is intubated. They have necrotizing pancreatitis because you've got this kind of haze obscuring both hemidiaphragms, the left lower lobe socked in, so you've at least got some left lower lobe collapse. But this patient, I think this is a great teaching case. You'll see on the CT done the same time, there's absolutely zero or close to zero fluid on the right. But on the left, there is medium-sized effusion, about similar in total volume to what's the right lung consolidation. And also, I think it's a great example of just enhancing passive atelectasis versus just this socked-in right lower lobe. And so this is presumably pneumonia or aspiration. I'm not exactly sure that this is, he's got a lot of other issues as well. But I just thought it was a cool example of how, the portable radiograph can really fake you out if you just guess here that you think there's probably an effusion on the right that's similar to the left, but there is almost none there. And then there's a delay, and you can see just the enhancement. This is from the pancreatic phase. But you can see the enhancement of the atelectatic left lung, and then the socked in presumed pneumonia in the right lower lobe.
And Travis, I think it also illustrates the point that radiography can't distinguish pleural fluid from consolidated lung. It's just white.
Right. So I thought this was a pretty cool example of this, and why, I don't know, my practice and how I was trained is always just, undercall effusions, or don't assume that just because you have this kind of hazy gradient that it is effusion.
Yep. Very nice.
And we'll show, sorry, Howard, say that?
No, a great demonstration of that. We see that a lot, obviously, particularly bedside radiography ICU patients, trying to distinguish particularly between pleural fluid, atelectasis, or combinations thereof. And I often dictate opacity in the basal hemithorax, which likely represents some combination of pleural fluid and adjacent lung atelectasis, not knowing how much of each is present.
Right. Yeah, that's what I'll often say. It's like atelectasis and or effusion. Yeah. And this is one that was brought to my attention from one of my fellows, and I think this is it may seem a little mundane, but I think it's a good teaching case because this is something that's a pitfall that we often see. And I think I know for me personally, the subclavian veins, you'll occasionally get venous dilation or focal ectasia or even aneurysm of the veins, especially near where you have valves that can mimic lymphadenopathy. And I think this is the best example of this that I've actually seen from an internal jugular vein, especially on this recent study. You can see there's a little heterogeneity here, and you might think that this is a lymph node adjacent to the internal jugular vein. This is a patient with head and neck cancer, and that's originally how this was interpreted. They had, somebody else looked at it and questioned that and brought it to our attention. And I'll show you some of their prior studies, and you can see how, I think on some of the earlier studies, that a little bit of heterogeneity here, but this is from a year ago. This is part of a PET that was negative, and you can see that this definitely looks venous, and it's contiguous with the rest of the jugular vein, and then at the confluence of the jugular and the subclavian vein. And then you can even go back further. Oh, this is a non-contrast, but you can see that it is dilated on here too. So it's an internal jugular vein. I don't know, do you call this just a varix or an aneurysm, or what would you call this? I mean, it's not a lymph node, that's the important thing, because it can be mistaken for one. And there's probably a valve right here, which increases the dilation right there.
I think probably varix would be a better name.
Yeah.
Interesting how it's totally dilated like that, almost circular.
Yeah, and in the patient, they actually have the same phenomenon on the subclavian artery, because I've seen a couple of these cases where it was called subclavian mass or lymph node, and then you look at it and say, no, that's just a focally dilated vein, and probably there's a valve in this area that's contributing to that. But just be on the lookout and, remember that not everything in that area is a node. So I will stop there, Jeff.
All right, thanks. All right, who'd like to go next?
I can go, Jeff.
All right, Peter. There you go.
All right, I'll start off with this one. This was a TAVR CT that was read yesterday by Art Stillman. He made a interesting finding, incidental finding here. So the abnormality is right here, and you can see this junction of the inferior vena cava as it comes up. You have this abnormal contour right there, right next to the right atrium. And we'd actually never seen something like this before. But one thing you can see here is that you can see the IVC coming up, and then it seems like there's another venous structure here, which is confluent at the junction there. And then this whole complex here appears confluent with the coronary sinus. So he was able to, Art was able to find a nice paper to show me. And then this paper kind of just gives a really good breakdown of coronary sinus abnormalities. And here are the categories. We're dealing with this category here, number 1, where there's an enlarged coronary sinus, and then within that, it's broken down left, if there is a left to right shunt present or not. And in this case, there isn't. And then, so the most common one, number 1, is persistent left superior vena cava, which I think we all see relatively commonly, draining into the coronary sinus and causing. But we thought this was a case of this, number 2 here, partial anomalous hepatic venous connection to the coronary sinus. And they do a pretty good job here. They have a nice section on this anomaly here, but essentially you have a vein, a hepatic vein, such, for example, something such as something draining into the phrenic vein, and that creates an anomalous channel and drains into the coronary sinus and gives it that abnormal look.
Yeah, can you show it again? Because I don't think I've ever recognized that before. So
I've never seen that before either. I was wondering if anybody had, but right there, and I can show it on the corona also. So it seems like this is the vein, right, the IVC, and then there's another vein here that's anomalous, that's also draining, and then causes that kind of this dilatation of that structure there.
Does it connect to coronary sinus or not?
It's the coronary sinus is right there also. Let me just pull that back up. So it seems like they're all kind of right next to each other. There's the coronary sinus.
so it's like the IVC, that vein, and the coronary sinus are all sort of connected to form seemingly one little bulbous structure. Is that it?
Yeah, exactly.
Something like that?
Yep. Okay.
Oh, very nice.
This is a case I've had on Monday. I showed something similar last week, but it was just a really impressive look for this. So this patient actually came in and got a trauma chest, abdomen, and pelvis CT at our county hospital. But we'll just go over the, actually we can start off with the radiograph. So severe or significant cavitation here in the upper lobe. And then in both lobes, we have patchy consolidation. You can make out some bronchiectasis down here in the lower lobes. And here's the CT. So he had a fall. I'll get to his other history later, but he came in also with the fall. So he got a chest, abdomen, and pelvis, and I think he had a small fracture in his pelvis. But the interesting findings are in his lungs, obviously. So if we start off with the left upper lobe, you're just looking at this, there's severe lung destruction here and cavitation, a little bit of thickening along the pleura. In the right lung, very abnormal as well, a lot of consolidation here with cavities. If we go up top, there are cavitating nodules. And then, so we go to the periphery of this consolidation, we start seeing branching tree and bud nodules here. So this is, this right there should tell you that this is endobronchial spread of a infection, and this was community acquired, this guy's coming in. And so the history is one or 2 months of productive cough and just not feeling well, weight loss. So this is just a good example of active TB. And this was confirmed by both PCR and sputum stain.
Yeah.
So I'll just go back real quick to the one I showed last week. Just a little distinction. Last week's similar stuff. Not this one was impressive too, but not quite as much as the other one. So we have cavities, tree and bud along the periphery here. This one is an AIDS patient, and you can see this necrotic lymphadenopathy in the AIDS patient, and you don't really see that on the case that I showed earlier. The patient wasn't immunocompromised.
But you can get that lymphadenopathy without immune compromise. It goes with primary TB.
Right. Yeah.
You know, just along these lines, in the last 2 weeks, I've seen 3 new cases of TB. I just wonder if it's resurging.
Yeah, I mean, this one I saw, the one I saw on Monday, and then this one is from last week. Yeah, so
You would think less, David, because people are not out in like crowded places for long periods of time in theory.
But maybe they're not going to the doctors, and then we're seeing the bolus now of delayed diagnoses that should have been spread out over the last couple of months. Maybe they're all being concentrated now that people are going back to their docs.
And you said that, and Peter, you said this guy had symptoms this patient had some symptoms for a while, but presented as
yeah. So yeah, and I didn't actually show everything on him, but well, I showed the relevant stuff. But he also had, he's had symptoms for a while, and he also has RCC. But then I looked at his chart, and he's had he's a drug abuser also. There's his RCC.
Oh,
I don't know how that's related, but
look how wasted he is. He's got no fat.
No,
he's got phthisis. This is phthisis. You don't see much. He's got it.
Yeah, he's lost a lot of weight the last few months, but yeah, it might be a combination of both the TB and the cancer. This one is a nice one. So this one, we'll just go down here first and show this one can serve as a mimic to some other diagnoses. But you can see if you follow this pulmonary artery here, you all of a sudden lose it right there. and put on lung windows, you can see mosaicism, and you go to the so there's so we have an obstructed pulmonary artery and mosaicism and enlarged bronchial arteries here. So it's kind of has in certain ways has some indirect, kind of seems similar to CTEPH in the indirect way, but it doesn't really look like CTEPH, right? There's no web. The filling defects here don't have that look. They're not web-like. And also a good example of systemic recruitment of systemic circulation to supply that segment of the hypoperfused lung from the, so we have some arteries coming from the celiac here recruited. So we have some transdiaphragmatic or transpleural supply there. But the clue here is that if you look at the patient's aorta, middle-aged female, by the way, so you look at the aorta, there's some thickening here, and there's thickening along all three great arch vessels. A chronic, this was a patient we've been seeing for a while now with Takayasu arteritis with pulmonary artery involvement.
Very nice.
Very nice, yeah. Just focal right lower lobe, huh?
Yeah, for the pulmonary artery, yeah. Right.
And how old was this patient?
I don't remember the exact age.
He looks young.
I think, yeah, maybe, yeah, she might have been, yeah. She wasn't super. I don't think she was like in her 20s, but she maybe like in the oldest in her 50s, but I don't remember the exact. I was gonna, yeah.
You know, it's interesting. I have now 2 cases in the past couple weeks that are young females. I'm going to try to I got to get all the bits together to present them, but both have pulmonary artery involvement of what looks like large vessel vasculitis. Both have inflammatory bowel disease, and there is a link. And one also has systemic arterial involvement of an axillary subclavian. Actually, it didn't have a pulse on one side. But one was billed initially as fibrosing mediastinitis, but I'll try to get it together for next week. It's worth showing, but that's interesting because I have a few other cases of Takayasu's involving pulmonary arteries, and I wonder if it goes underdiagnosed or people think it's something else because it's not what you typically think about. And and the ones I have no aortitis at all.
Yeah, usually, I mean, I usually see the aortitis way more commonly.
Right, right. That's what you think about is aortitis. But I know the literature says at least the pulmonary involvement is not that uncommon. But without aortitis, I don't know what that number is. And it's such a rare disease anyway. But that's interesting. You have one too.
So Jeff, your cases, were they symptomatic before the COVID era? I'm just wondering if
one of them's like a couple of years old and was, as you know, it was labeled fibrosing mediastinitis. The other case presented, yeah, it was pre-COVID. She actually had a PE years ago, or a couple years, maybe it was a year ago, but pre-COVID she had a PE, and that's why it was originally thought to be maybe. And she had some infarcts. Maybe this was chronic PE, but there was too much thickening in the wall. I'll bring them next week. It'll be worth talking about. In Peter's case, is a perfect third to go along with that because you got those nice collaterals, which fibrosing mediastinitis should not have central collaterals because that's all fibrosed and down. You get more transpleural, and you've got those nice big juicy arteries there. But your case is reminiscent of mine, so I'll have them for next week.
Sure, yeah, that would be great. I have 2 more, but I can let somebody else go, and then if there's time, I can show my other 2.
Okay, yeah, there probably will be time, so we'll circle back around. And we can let's see who, Howard or David?
Nothing from me this week.
Okay.
I have one to show.
Okay, and I've got a couple I can do as well.
Okay. So this is a nice opportunity for rad path correlation. Here is the chest radiograph of a person showing mostly basilar abnormality in the chest, These opacities are obviously subsegmental sized. And having a chest radiograph like this, you wouldn't be able to make any kind of diagnosis other than to suggest some form of lung disease is present, but we don't know whether it's acute or chronic. What may be atelectasis, what may be consolidation, what may be neither, some kind of fibrosing disorder or combinations thereof. So here are some images from a couple months later. I'll just give you the big picture on these relatively thick images. So we have multifocal, multi-lobar, geographic ground glass attenuating opacities. In some regions like this, the opacities are more attenuating, more consolidative. Variable shapes and sizes, and more in the lower lung zones. So again here, how much is some form of infiltrative lung disease, because the presentation is not that of an acute febrile respiratory illness, and how much is consolidation, or exactly what's going on there, really hard to say. So the context was, as I said, not an acute febrile illness, and I'll show you in a moment that the presentation wasn't suggestive of any particular thing, but someone got an ILD panel and found an ANA antibody that was a bit high, and there was a question of a prior rash, although a rash was not present at this time, and a question of joint pains or inflammatory arthropathy. So things were not very clear. But clearly, because this patient has not an acute illness, not a febrile illness, they went quite quickly to do a surgical lung biopsy. So I will show you that.
So Howard, before you go ahead, I mean, to me, I would look at this and say this is like an organizing pneumonia pattern of injury. It's pretty typical.
Yeah. Yeah, definitely. Multifocal, multilobar, variably sized opacities in the lungs. But
I'll be curious to see how helpful the biopsy is, because in our experience, it just shows acute lung injury and the differential is so broad. Occasionally, you might see something that points you toward a connective tissue disease, but it's usually not enough to by the diagnosis.
Exactly. So I can tell you that her initial, other than the ANA that was elevated, the other things in terms of the ILD panel for connective tissue disorders were all negative. There were no anti-synthetase antibodies, anything else they were positive other than that. And certainly I would think of organizing pneumonia or connective tissue disease associated lung disease, of which organizing pneumonia is often a part, of course. So it turns out here this is actually quite interesting, and this is nice because I have some annotated images to show you. So here is the history. There is the pretty large titer of ANA. And here I'll show you the images. So I'm going to make this bigger. It was noted at the time of surgery that there were a lot of pleural adhesions. So there's definitely involvement of pleural surfaces. And this is the pathologist's labeling of pleural membrane abnormality, the pink. Then we have in the lungs, that is relatively low power, but there's another one here, which I'm going to show you that in a slightly higher power. So let me just go up here, see if I can find that one. Give me a moment. Okay, so this here is in higher power, and I'll bring this down, of a really nice example of a lymphoid follicle. And the two arrows here indicate airway epithelium. So we have lymphoid follicle. We don't have germinal centers, but certainly that's what the pathologists will look for. So far we have pleural abnormality, and we've got lymphoid follicles. And then the last thing that shows what the lung disease is this one, which is nice because it is an organizing pneumonia. So let me bring that up and mag that up. But this is what pathologists call a blue biopsy, in the sense that what we see here are the cells. So there's a very large number of cells that fairly uniformly but substantially widen and accumulate in interalveolar septa. So we have lymphocytes and plasma cells. So it turns out in this person, we don't actually have an organizing pneumonia, but we have here a very nice demonstration of cellular NSIP. So the combination of pleural disease, this pathology, and the lymphoid follicles for a pathologist, very distinctive for connective tissue disease associated lung disease. So that is the diagnosis. And then, of course, if I bring this up again, because of this presentation, we certainly should wonder about, I'll make this big. You know, this sort of fits in part with this notion of IPAF in part. So we certainly have, you know, she really does have inflammatory arthritis. She didn't have a rash at the time they saw her, but you look in the clinical domain, we have a positive ANA, so we have something from the serologic domain. And of course, we have both imaging and histologic findings from the morphologic domain. So we pretty much have everything that fits into this provisional category of IPAF, as you can see here. So I think that's.
So
Howard,
Howard, given the organizing pneumonia pattern and some autoimmune suggestion, I don't know if you have it available or if they sent it. There's an extended myositis panel that has additional antibodies that's not part of the routine rheumatologic workup. And given that that's probably the most common connective tissue disease to present with this pattern is myositis, that would be something interesting to see if they sent or if they're able to send, because we've had several patients that are IPAF-like and the extended myositis panel comes back positive, and they often have a very high ANA.
Yeah, I'll have to look.
Howard, did they look for IgG4 in, did they stain for that?
No, no. I think the pathologist recognized this pattern. I mean, I'm not a pathologist, but even I recognize that this is pretty typical for so-called cellular NSIP pattern up there. So no, they didn't do that. They felt pretty confident, I think reasonably, that the findings fit very nicely for a connective tissue associated lung disease.
So it's autoimmune, but I think IgG4 qualifies as autoimmune. So the question is, what's driving it? And so the myositis panel, but also IgG4 staining might tell you what's driving this autoimmune disease.
Yep. Yep. But we don't have actually any organizing pneumonia as such. So even though it sure looks like that, this indicates that we're not always correct about that.
Howard, do you think maybe if, was this at all long-standing, her symptoms? Do you think maybe if there was a biopsy done like years earlier, it might have shown OP?
No, no. No, there was no prior biopsy in the past, no. Pathologists attach a lot of importance to the pleural abnormality in thinking about connective tissue associated lung and pleural disease. But no, there's no prior biopsy.
Well, interesting case.
Yeah, I think it's nice red path correlation.
For sure.
All right, that's mine,
All right.
Jeff.
Well, thank you. All right, well, let me show a few here. Why is it not? Let's hit the right button. There we go. So this is a 62-year-old female who was a kidney transplant recipient. It was been several years out, and presented. I don't remember the exact something. I think routine clinic visit or something. And may have had a cough, but nothing. Not acutely ill, and has this nodule here on the frontal radiograph. If we go to the lateral, Nodules hiding back in here. So solitary nodule in a transplant recipient, you think of PTLD, but I think she was kind of far out, so that would have been a little unusual. Infections, of course, are common. When I see big nodules, I think of nocardia. I think of cryptococcus, are the big ones that I think about for large nodules. And of course, malignancy is always a concern. So she had a CT scan, and the CT scan shows this sort of bilobed, well-circumscribed, fairly large nodule in the lateral basal left lower lobe there. So CT doesn't really change the differential at this point, but you need tissue. On the soft tissue windows, I think it was just intermediate attenuation. Yeah, it's got a little bit of low attenuation in it, but not really necrotic, nothing calcified. So in this case, you kind of need to put a needle in to know what it was. I think they did the usual workup and nothing panned out. So this ended up being cryptococcus. And I know Dave is going to ask me which species, and we don't have that because it was not grown out of culture, but I think they did some kind of PCR on it or something, or an antibody to it. But either cryptococcus, probably neoformans out here, but there is gaddii too, and either can occur in transplant patients. So, and this was interesting. I didn't save the other images, but it had actually persisted over several studies, even with treatment. So it may just be some granulomatous inflammation that's sort of scarring down over time, but you can get sort of a chronic cryptococcus that doesn't do anything. There was no CNS involvement or anything else, but it's in the differential, though, for a pretty large, well-circumscribed nodule in an immune-compromised patient, and very rare, but does occur in immune-competent patients who may have a subtle immunodeficiency. So cryptococcus, one I don't see much, don't seem to see as much anymore than we used to, and it may be with some of the usual voriconazole and other things they're put on. At least initially, we don't see that. This was kind of cute, something I never really gave much thought to. So this patient has an empyema, and you can see that's not why I'm showing this, but and has a or I should say a complex effusion, and has a pleurax drain in. So I'm sorry, well, it is an empyema now, but a complex effusion. We see pleural thickening. The left lower lobe is unhappy, and had a pleurax in to manage this. And it was a malignant effusion, but interesting, there was a lot of pus coming out. And what's kind of cool is if you look in the chest wall where the pleurax is, you'll see there's actually fluid tracking around the drain. And we usually don't see that with these pleurax. Often we don't even get a CT. They're often just followed with radiographs. But the interventional pulmonologists were concerned that there was the entrance site looked angry, and there was some pus in there as well, that this was infected. So I suspect it's an infected chronic pleural effusion that's tracking along the drain, and you can see a little bit of cellulitis there. And that's just, I'm sometimes not really thought much about, but we do see it with I guess the equivalent we do look for is with LVADs. When you can see driveline infections, you can see just some stranding around the driveline. But in this case, we actually have what looks like contained fluid. Interesting, the fat around it is fairly clean. So I wonder if it's formed a little track.
But Jeff, did you say there was malignancy here, or was this all just?
I believe this was a malignant effusion, hence the pleurax, and I think this effusion must have gotten infected. That's why you have the empyema and this unhappy-looking lung. I don't remember the underlying pathology of it, but we don't typically put a pleurax into an empyema. We would put a pigtail in or a large bore drain after they cleaned it out. So. But it was from talking to the interventional pulmonary fellow, the site was pretty red and angry, and there was a lot of just pus and stuff. So super infected. But I've not seen a pleurax ever get infected before. So this one happened to have imaging. So just something to add to your list of things when you do see drains in chronic things, is to make sure you check not just where they're located, but follow the track there, because it'd be very easy to overlook that when you have all this going on in here. Okay, we showed those last time. Let's see. So Vasilio sent me 2 nice cases of Birt-Hogg-Dubé, and I'll show them real quickly. The first patient worked as a welder for many, many years, and has this CT. Had no family history of pneumothorax or anything. But this CT shows very nice Birt-Hogg-Dubé type cysts. We just see the basis right here. I don't have so many images. Let me, there we go. But you can see they're basal predominant, sort of what's been described as a floppy cyst. They like to be near veins. There's often vessels running along them. And and he had no history, as I said, no family history or anything. And I think we get far enough down. Yeah, he's got just a kidney cyst there, no mass. But what's kind of cool is, so he was telling me that the genetic testing in Greece is extremely expensive. So it's not always an option for people. But the patient presented, he had these little, there's the lesions right there, these little white papillary lesions. And so these are the fibrofolliculomas, and they could be pretty subtle, but you can see there's a bunch of them. But they had been attributed over the years to welding and sort of a contact dermatitis. And so they weren't recognized. But knowing that he has these lung cysts and all that, they thought there was Birt-Hogg-Dubé. And so they did a skin biopsy. And lung biopsies, I can sort of like slog my way through. Skin biopsies, I cannot. But clearly this looks like some kind of abnormal squamous epithelium here, but this is what a fibrofolliculoma looks like, and you can see this sort of thickened squamous tissue there. So the pathology in this case, they were able to confirm a diagnosis based on a skin biopsy and a CT scan that's very consistent with Birt-Hogg-Dubé without the need for genetic testing. Because I know in the U.S. we send off for the folliculin gene, and I have no idea how much it costs, but I'm sure it's very expensive here. And you can imagine in other parts of the world, depending on, especially if you have either single payer or national payer healthcare, that they may limit the utility of that. But this was enough to, I think, make a confident diagnosis. You've got the skin findings. And like this patient didn't have a family history. So sometimes, even if there isn't a family history, it can be, I guess it can be a de novo mutation. And then there's a companion case. This was a 55-year-old who also had these very subtle fibrofolliculomas. And he was saying he almost overlooked them, but knowing the patient had cystic lung disease, which I'll show in a second, you can look for them very carefully, because we've seen cases, and a lot of the ones published in people's lectures. I know we did a paper years ago on skin and lung, and the one we had pretty profound skin findings, but they can be subtle. But I think most of us are fairly comfortable with the pattern of cystic lung disease associated with Birt-Hogg-Dubé. These are interesting. In the upper lobe are rounder, and you might see that more with like an LIP pattern. But as we go down, you'll see they become more floppy looking, and they really like to be along the pleural surfaces and on the junction of the interlobular septum and the pleura. And of course, no other cause like connective tissue disease. But I know there was a recent paper that described this floppy appearance. These are perivascular, so I think LIP would be a pretty strong differential diagnosis as well. But in the absence of connective tissue disease, immunodeficiency would be unlikely to have just cystic LIP with not much else going on, and then the fibrofolliculomas. But you can diagnose Birt-Hogg-Dubé sometimes, depending on resources, with a combination of chest imaging. So in this case, I think the chest imaging informs the diagnosis and makes it easier to think about this disease, because it is pretty rare. It was very popular in the mid-2000s when the first radiology papers came out, but I don't think we had a gene test quite then readily available. So I'm not sure how many people were Birt-Hogg-Dubé that really aren't. I don't know. But anyway, it has implications, of course, for screening for renal cell carcinoma, genetic counseling. Of course, these are older patients, so less genetic counseling just for any children they have. But yeah, just two nice cases of Birt-Hogg-Dubé.
Very nice. Great, thanks.
All right, Peter, we should have time now for if you want to show your remaining cases.
Okay. This is one that's been shown before, but I think it's just a diagnosis that gets overlooked, and so I wanted to show it. It's kind of impressive. So he is a 19-year-old patient, and he's coming in for a MVC. So he's getting a trauma workup. This is his chest radiograph when he came in, and there's kind of diffuse bilateral consolidation here, but not much trauma to the chest. And here's his, but then you can see, so let's go back to this one. 1 hour later, or 2 hours later, this consolidation is getting worse, a little bit worse on the right side, but significantly worse overall. And here is this chest CT in the abdomen and pelvis. This is part of the trauma workup. And so here are his lungs. And this is a good example of an acinar pattern of ground glass nodularity. And you can see it's very diffuse. There is subpleural sparing. So it's kind of a central lobular pattern. So that kind of tells you this either came in through the airways or it's a vascular abnormality. And I think these often get called multifocal pneumonia. But you can see here in the airways are pretty clean. It doesn't look like an aspiration really. And I think this was a vascular problem. And the clue here is
a traumatic lung cyst on the left as well.
There was, yeah. And I think actually this was, I think this was dictated as there is a cyst here. This was dictated as pulmonary contusions, just ground glass, consistent with the concerning for pulmonary contusions. But I wasn't.
Oh, he's got more than one.
I read the follow-up video.
Traumatic lung cysts on the other side.
Yeah, so there is a traumatic abnormal, like a little laceration probably here, but there's no rib fractures anywhere. So I thought this ground glass was just out of proportion to represent contusions.
There's another one in the medial lingular, Peter. I don't know if they put that one.
Take a look.
Medial lingular next to the heart. Traumatic lung cyst with a fluid level, I think. Yeah, there. Go back a bit. There. There.
Mm-hmm. Oh, there, yeah. But here's he had fractures in his pelvis and his right femur. So I thought, and then let's go back to the radiographs. So this is right when he came in, and then the following day, significant improvement, and it's essentially resolved like about 2 days later. So I thought a lot of this was fat embolism.
Yeah, for sure.
But the timeline doesn't really fit, right? Because fat emboli shouldn't be on the first image because they have more of a delayed presentation. Right? You're saying this is their initial presentation, right?
Initial presentation was this. This one here this was the initial one. So he had some.
Okay, so he has some, yeah.
Then this one on the bottom right got significantly worse within 2 hours later, and I'm not sure if they manipulated him or something in the trauma bay. So this one on the bottom right is only 2 hours later, and then this is the CT of the chest at the same time as this radiograph. So to me, I didn't think this was aspiration, and I didn't see any rib fractures anywhere here to cause such a diffuse.
Yeah, and you'd be really hypoxic if that were all contusion.
Right, and
really hypoxic.
It resolved pretty steadily over the next 2 days. So just combined.
Did he have other symptoms of fat emboli syndrome?
You know, it's like I was trying to find the notes weren't very good. It was just he was basically managed by trauma surgery, so I couldn't really. I was looking through his notes and I couldn't really. They weren't very detailed. And,
so Travis, how long is it supposed to take before you're allowed to have fat emboli manifest on the chest?
I thought it's usually like 1 to 3 days, right? Because it's a chemical pneumonitis. The fat has to to get there and be broken down into fatty acids that cause the symptoms.
Yeah, and yeah, that's usually that's what we have from.
I've seen it in patients who I've not seen a case acute traumatic, but I've seen them all post-op, usually post-op day 0, after getting their femur or whatever fixed in the OR, where they put a big rod in. And I always thought the manipulation in the OR and all that led to the embolization. And
but Jeff, to your point, I mean, does contusion cause severe hypoxemia?
It should, because it's blood, and if you imagine, it would the blood binds all the oxygen. That's my experience. Patients with diffuse alveolar hemorrhage often are pretty hypoxic. Well, we can ask Vasilios. He's a pulmonologist.
Interesting. I hadn't really thought about that.
Yeah.
So Jeff, I would disagree, because I've seen cases of there are two things that cause a lot of lung consolidation but not much hypoxemia, and those are edema
For sure.
and hemorrhage. I've seen a lot of patients with pulmonary hemorrhage. Their chest radiographs look horrible, but they're actually oxygenating pretty well. So I think it's fairly well tolerated. Now, people who have diffuse alveolar hemorrhage in the bone marrow transplant setting, they have a lot more problems than just the blood in their lung. So I don't think that's a good group to compare. And I've seen fat emboli sort of manifestations when people come out of the OR from spine surgery, where they had a lot of pedicle screws placed. You know, I think when you screw something into bone marrow, you mobilize a lot of stuff into the circulation. And I don't think it takes all that long to get manifestations and shortness of breath from fat emboli in acute trauma. I don't think it necessarily has to take 1 to 3 days.
Yeah, I've always seen it like right after surgery. I never thought of it as a delayed onset, because usually they're hypoxic after surgery and they're a little goofy looking or acting, and you give them some oxygen and most of them do fine.
Yeah.
And usually acute lung injury from fat embolism is symmetric. There's bilateral symmetric lung edema.
Yeah.
And this one, there's a lot more abnormality that developed in the right lung.
The other thing is, usually with fat embolism, I usually tend to see them at the lung bases, and I'm not sure if that's just dependent on the positioning, but it looks very similar to acute chest syndrome in sickle cell patients, but it's a little bit more basilar than this. But for me, that's what I thought this was still, regardless. But
you know, I think the other thing that's going on here, we don't know what position this guy was in when he had his motor vehicle crash. Maybe he was prone for a while, or sitting and slumped over to one side, and his blood circulation was going to carry any fat globules to that side selectively. We also don't know how long it was since he had his trauma before you got the first radiograph. I mean, it could have been several hours.
Exactly. I was gonna. Yeah, that's a good point. Is that we don't know actually. The notes weren't very good, so I'm not sure how long he was before he actually got brought into the hospital and when this radiograph was taken. So. Yeah.
Hello, I'm Vasilios. Well, in my experience, usually patients that have extensive consolidation or granular opacities due to alveolar hemorrhage, they tend to be really hypoxemic. So I think from a clinical perspective, it is important to know how the clinical picture evolves over time. So what was the status of the patient arriving at the ED and how he evolved during his admission at the hospital.
Yeah, and unfortunately, I don't have much of those details. I don't think he was intubated, and it seems like this kind of resolved and he's doing well now. You can see his radiograph on the right side. This is his most recent one, so he's kind of back to almost normal. But I can try to dig farther in, but the notes weren't very good for this. And the notes were mainly about his trauma towards his lower extremities.
And also, just a question to all of you: do you think that the time frame regarding the resolution of findings is compatible with fat embolism? Because it was a rather spectacular improvement on the chest X-ray.
From what my observations is that they resolve over a few days pretty well.
And what is the time frame in this case?
Here, I can show the, so he came in on the 18th, and then the image on the top right is on the 22nd, so 2 days.
Great case.
Yeah, for sure.
Yeah, we'll
Okay.
never know. Infusion versus that. Yeah, it's interesting.
All right. Well, thank you everybody for the great discussion today. It was good cases. And we will talk again next week. And Travis, you said you'll be away next week.
Correct.
All right. Well, see you when you get back.
Enjoy.
See ya.
Bye, everyone.
Good night.
Bye, everyone.